Muy bien.
Perfect. We're ready to go.
I have sent a link to some colleagues, so they will be able to join.
Yeah.
Okay.
It's an open link. They should just be able to come in, and
Perfect.
and we're having people starting to show up now. We had some people log in like an hour ago from Africa, not realizing what time. So I hope they come back.
Vale. Okay.
Yeah. So it looks like everything's ready to go. Thank you so much for
No, it's a pleasure. Thank you to you for helping with this and in the invitation.
The people
I will be using the mask, sorry, because I'm in my parents' house, and I prefer to take some, so that's the only.
I just flew home last night from Eastern Europe, and so I'm working from home because I have no idea what to pick in the airport. I'm just so paranoid about the airport. So
Yeah. Sí.
all of my friends that travel have got it. So I'm really like,
Yeah. And I just arrived from Mozambique a few days ago, and I prefer also to take some precaution.
Yeah. So you're at your parents' house. So it looks like you're outside though.
Yes. I'm outside, but they are moving around. Yeah. Maybe they will be attending the presentation.
Do a drop in.
Yeah.
A photobomb you. Put your head.
Yeah.
People are really excited to hear your talk. I know everybody's very excited to hear this. So.
Oh, nice. Happy to hear that. I'm also very excited to share with you the work we are doing in Mozambique.
And I can see people starting to like tumble in through the link.
Hola, Brian.
Hola, how are you?
Fine, and you?
Good. Hey, Teresa, are you home?
I am home, yeah. I got home late last night.
Oh, wow. You're probably exhausted.
I'm fine, but I'm nervous that I might have caught something, so I'm
Oh, no.
home. And also, I noticed that you never picked up the machine that's on the front porch.
That's correct. Yeah, I got the message too late, and we just did without it.
That's okay.
It was for trivia and stuff, but we just projected. It was fun. So, we had a seminar last week, Alfredo. It was really nice.
A retreat.
A retreat.
Oh,
sorry.
Okay.
This is a seminar. That was a retreat.
Whole day retreat?
Sorry, say that again.
Whole day retreat?
Oh, it was 2 days. Yeah, we left on Wednesday and we came back on Friday. So we had Wednesday night. We had we did a barbecue and had trivia and some games and stuff. And then Thursday was a whole day retreat. And then Friday we did some hikes before coming back.
Okay, good.
Yeah, it was nice.
Yeah.
I'll see you in Seattle. Yeah, you'll be there?
No.
Oh.
Not this time.
Okay.
Now I just arrived to Spain from Mozambique to meet my parents. There are some issues. Well, my father has some issues with health, so I came just to be with him, and I will be coming back to Mozambique in 3 weeks. So I decided not to go to STMH this year.
Yeah, you said there's a lot of activities going on right now in the field.
Yeah, and the sampling activities. So I prefer to focus now. And next year will be the opportunity to present many results.
Okay. Yes. Fingers crossed.
So you are going, of course. You are going to Seattle.
Yeah, it's the closest it's ever been for me.
Sorry, what you said?
So did you say I'm going to Seattle? Is that what you said?
Yes.
Yeah.
I'm asking if you're going to Seattle.
Yes, I'm saying it's the closest ASTMH has ever been.
Okay.
From San Francisco. Yeah, it's a very short flight. Although it's never that bad from the US.
Yeah. Mm-hmm.
It's much further for you or people from, say, Australia or elsewhere.
Claro. Sí.
We'll wait a few minutes.
Can you hear me well like this? Better or can you hear me well?
Sounds fine. Sounds about the same to me. I don't know what you think, Teresa.
It sounds about the same.
I will not use. Okay. Good.
So you said you're currently in Mozambique?
No, I'm in Spain.
Oh,
I arrived on Sunday. I came just to spend few days with my parents.
okay.
Yeah, and then I will be here for 3 weeks and then come back to Mozambique.
Okay.
Yeah.
And what percentage of your year are you spending in Mozambique versus Barcelona now?
3-4 months in Mozambique, 1 month in Spain.
Oh, wow.
Yeah,
Okay.
more or less. Yeah.
So you've become Mozambican.
Yeah. Yes, I'm becoming Mozambican. Yeah. Oh, it's nice. I'm enjoying to stay there. The only is to combine with family and my partner and all this. But anyway, we are doing well.
Good. I guess you've got good food options both places.
Sorry?
You have good food in both places.
Sí. Sí.
All right, we'll just wait a few more minutes.
And you are traveling after Seattle? You are going somewhere, Brian?
I think actually I have no more work travel until the end of the year after Seattle, which will be nice. Yeah, probably early next year there'll be more travel.
Okay.
Probably West Africa and East Africa, and then probably Southern Africa again, maybe later in the year.
Okay.
What
Let me know
about,
whenever you can jump to Mozambique, Brian.
Yeah, I've still never been.
Yeah, we have to organize that.
what about Andres? Is he home for a while or is he traveling again?
No, unfortunately, he is. He's actually on his way to Belgium right now for our Gates Grand Challenge meeting, and then he'll be talking about some metagenomics sequencing work that the BioHub is supporting, and then he'll be at ASTMH, and then back again. All right, we'll just wait a few more minutes. I think sometimes we get some people around 5 after.
We have 25 people on the line right now.
Okay, great. Sorry, I have my screen, so I haven't been able to see them all. All right, we'll just wait until 5 after, and then we'll introduce Alfredo and get started. We've got some people from the GenMaz team, which is great,
Yeah.
and from MEI. Alfredo, do you know about the MEI group here at UCSF, the Malaria Elimination Initiative group?
Yeah, not much. Yeah. But what I have read is, but not. I don't know the details.
Okay, so they're also at UCSF. I know Allison or Jenny, if one of you just wants to kind of summarize your group briefly.
Sure. Hi, everyone. Morning. I'm Alfredo. Looking forward to your talk.
Thank you.
So yeah, the MEI is another malaria group at UCSF. We're about 35 faculty and staff here, and so we work with countries to support their malaria elimination efforts. Our work is not lab-based; it's field-based. We do field research, consensus building, convening, and we also provide technical assistance and capacity strengthening to malaria programs across a range of areas, including vector control and surveillance, parasite surveillance and response, advocacy and financing, program management and leadership, and drugs and diagnostics. So yeah, happy at some point to connect and would love to learn more about your work. We actually collaborate. I think, yeah, you work with CISM. So we actually have several collaborations with CISM, especially on entomology. So work with them closely over now the past six years or so. So that's a bit about us. Yeah. So nice to meet you. And
nice to meet you also, Alison.
Yeah, thanks.
and we're fortunate, those of us in the division of HIV, ID, and global medicine that do malaria work as well, which is me and Jessica and Grant and Phil and Melissa and Isabel work really closely with the Malaria Elimination Initiative on some projects. So it's a great partnership here. All right, well, let's get started. We've got 26 people plus the room. So it's my pleasure to introduce Alfredo Mayor. He's a research professor at two institutions, the Barcelona Institute for Global Health, or East Global, in Spain, and the Manisa Research Center, or CISM, in Mozambique. He has a PhD from University of Barcelona, did postdoctoral research in the Center of Genetic Engineering and Biotechnology. And he's going to talk about some of his research today, but really he relies on 4 key principles to advance the malaria scientific knowledge to improve malaria control and elimination, prioritization based on programmatic needs through dialogue with the NMCPs and other stakeholders, translational approach building from host-parasite interactions, and empowering the new generation of researchers in Mozambique and other malaria endemic countries through capacity building and rooting research in the country. And I've had the pleasure of being able to work with Alfredo on one of those projects recently, the GenMaz project, which he may touch on during his presentation today. And it was a nice collaboration. I was very excited to have the opportunity to work with him. We've always met at meetings and things, but never really had a chance to work together on a project. And then we met at a meeting in Geneva where we're talking with the WHO about potential use cases for genomic epidemiology, and talked about our shared interest in doing such work. And I'm really pleased to be part of his team on the GenMaz project. So with no further ado, Alfredo, I'll let you talk to us about surveilling and reacting to malaria.
Thank you very much, Brian, for the introduction. Hello, good morning, good afternoon to everyone. Teresa, may I ask you to advise me, tell me when we are 40 minutes, just in case, yeah? Just in case
sure, I can do that. I'll
Thank you very much.
Sure.
Great. So yeah, it's a pleasure to share with you the work we are doing in Mozambique and Spain. As Brian explained, I'm a researcher at these two institutions, CIS, the Manisa Health Research Center in Mozambique, which is a research center in southern Mozambique, 70 kilometers to the north of Maputo, where there is this research center in front of the district hospital. And here you can see on the left some pictures of the center. And I'm also a researcher at the Barcelona Institute of Global Health, which is affiliated to the University of Barcelona. So just to give you an overall view of my work, I lead the malaria physiopathology group, which is focusing on understanding host-parasite interactions, especially those that are affected by changes in transmission, with the idea of applying this knowledge to develop new surveillance and improve the epidemiological studies. And in the context of these activities, we are conducting this research on ANC surveillance, antenatal care surveillance, serology, and genomics, with the final aim of using all this knowledge to provide action for malaria control and elimination, and also building capacities in malaria endemic countries, mainly in Mozambique. So I will move now to the core of the presentation, which is related to malaria in pregnancy. This is an area I've been working on during the last 15 years. Of course, malaria in pregnancy is a very important public health issue because of the pregnant women are, together with the children, one of the most affected populations by malaria. And here you can see two examples on the right of the impact that this infection in pregnancy can have on the newborn, low birth weight, stillbirths, and on the mother. This can lead to anemia, severe anemia, and eventually to the death of the pregnant woman. studying also malaria in pregnancy is very exciting, not only because of the public health impact, but also because there are some more or less clear mechanisms that explain these increased adverse effects of malaria in pregnancy, which basically is this accumulation of malaria parasites in the placenta, as you can see in this picture. The parasite has developed mechanisms to sequester in the placenta through cytoaddition to chondroitin sulfate A in the placenta using a molecule of the parasite, which is from the family of PFMP1, BAR2CSA, which mediate this interaction. So pregnant women develop immunity against this specific antigen in a parity-dependent manner after exposure to these placental type parasites during successive pregnancies. And this is the basis of some initiatives aiming to develop a vaccine based on this BAR2CSA molecule, and also opens some exciting opportunities for developing serological approaches for surveillance based on the development of antibodies against this specific antigen of the parasite, BAR2CSA. So currently, the WHO recommendations, the tool we have to prevent malaria in pregnancy, relies on the use of insecticide-treated nets, which are given to the pregnant woman at first antenatal visit, and also on the use of IPTP, so intermittent preventive treatment, basically the administration of SP, sulfadoxine pyrimethamine, at each antenatal care contact, starting from the second trimester. However, this strategy has several gaps. First of all, women at first trimester cannot receive SP because of the teratogenic effects, so they remain unprotected. HIV-infected women who are receiving cotrimoxazole can also not receive SP, so again, they remain unprotected. Resistance to SP is increasing, to very high levels, so this is again leading to some concerns on the effectiveness of the intervention. And also there are issues of attendance to antenatal care clinics. Here you can see some figures on the top. It represents the percentage of women attending at least one antenatal care contact, one visit, which is relatively high in most African countries, above 80%. This is one visit. However, in the bottom, that part in red, you can see that the percentage of women who attend 4 or more times through antenatal care visits is much lower. So we are moving from places where this percentage is 20–30%, such as Mozambique, and other places such as Nigeria, which is higher. But there is a lot of opportunities to increase this coverage. Because what is clear is that antenatal care clinics is an opportunity to improve, to deliver strategies, not only for prevention of malaria, but for other purposes such as anemia, HIV, and so on. And antenatal care clinics offer also an interesting opportunity for surveillance. Basically, pregnant women attend antenatal clinics for antenatal care, and this is an opportunity to test for diseases and provide indicators of what is happening in the overall community. This approach has been used for surveillance of HIV since several years ago and has been useful to generate estimates of HIV prevalence in Africa, for example, and also to monitor trends in countries, no? Such as you can see here on the left, trends of HIV prevalence in South Africa based on ANC data. So what we are trying to understand is which can be the value of an ANC-based surveillance approach for malaria. And to start with, what is important is to understand which is the added value of this approach compared to the standard ways of surveillance that are used in most African countries, which basically are three. Two. ANC could be the third one. No? The first one is population-based health surveys. Cross-sectionals in the community. Go into the community and test individuals for malaria and produce the estimates on how much malaria is there in the community. And of course, this is ideally the best approach because it produces a direct measure of what is happening in the community. It captures asymptomatic infections. And there is a very clear denominator, the population at risk. However, this can be done only periodically because it's expensive, it requires many resources, and usually it is done every 3-4 years. Now, in Mozambique, for example, the teams are preparing to do the malaria indication survey based on this approach, which is going to happen in early 2024. And another con of this approach is that it is affected by refusals and absence when the teams go to the houses to recruit the population. The other approach is based on passive case detection, so basically recording the malaria cases, so symptomatic cases with a confirmation by RDT of malaria infection, which is done as per routine in the clinics in most African countries. So this is an established approach, well distributed. It provides continuous information. It's based on test positivity rate, which is more stable. However, it misses symptomatic infections. Asymptomatic infections, which we know are very abundant. There are some uncertainties about the denominator, the population denominator, the population at risk. It's also affected by health-seeking behaviors, and does not provide information on malaria in pregnancy, the risk and burden. So ANC-based surveillance could potentially provide alternative measures to triangulate these two sources of information, the population-based health surveys and the passive case detection. And antenatal care clinics are well distributed. There is a high attendance at least one time, and can provide continuous data. It captures asymptomatic infections because the pregnant woman goes to the clinic because she's pregnant, not because she is sick. And there is a more clear and stable denominator to produce estimates, and can potentially improve care of pregnant women. However, there are concerns about representativity, the impact of diagnostic sensitivity, and of course, the additional resources that this strategy would imply. So, in my group in Barcelona and Manisa, we are working with trying to assess the added value of this approach. And for this, we are combining different tools to assess which can be this added value. On one side, we have the malaria test, basically, the RDT, which can produce the results on infection, parasite infection. We could potentially also collect information at that first antenatal care visit about coverage of interventions, such as the use of insecticide-treated nets in the household, health-seeking behaviors, what the mother does with the child when he or she is sick, and so on. This type of information that is captured only in the malaria indication surveys every 3-4 years. We could potentially use genetic tools to characterize the parasites infecting pregnant women at first antenatal visit, and serology, basically antibodies against Bar2CSA as a marker of exposure during that pregnancy. The combination of these tools could potentially allow us first to estimate the burden of malaria in pregnancy, which most of the countries lack, and improve healthcare at antenatal care clinics, allowing the detection of, for example, infections at first trimester could allow us to treat those infections, but currently this is not done. And as I said, pregnant women at first trimester not eligible for IPTP. Information about parasite infection on intervention coverage could allow the national malaria control programs to produce, to stratify the burden of malaria and the use of interventions and guide eventually control intervention at a scale. We could use also the information from pregnant women to infer the intensity of transmission in a given area and the impact that interventions are having or at the level of transmission. We could also develop reactive responses based on those cases identified among pregnant women at that first antenatal care visit, especially in low transmission settings targeted for elimination. And the use of genomic tools could allow us also start the parasite biological threats, such as antimalarial resistance or diagnostic resistance and escape from vaccines and so on. So we are building all these questions from previous data that has been already generated. There was a meta-analysis conducted by the team at the Liverpool School of Tropical Health, where they showed that there was a good correlation between prevalence of malaria in children and pregnant women. What we are trying to address are these questions. So basically to understand which are the factors that affect the correlation between malaria burden at first antenatal care visit and the community, which is the added value of ANC-based data to detect malaria hotspots, the added value against of pregnancy-specific serology, and the potential use of genetic data from parasites collected at first antenatal visit to understand what is happening in the overall parasite population. So to address these questions, we started a few years ago a project funded by NIH, which allowed us to conduct a 3-year prospective observational study where we recruited pregnant women at first antenatal visit at 3 clinics in southern Mozambique, as you can see in this map. So in Manisa district, where the center is located, which has around 160,000 population, we selected 2 clinics in this district, one based in Manisa itself in the village, which is a historically low transmission setting in the last almost 5-8 years. In Iyayosina, which is a rural area, which historically high levels of transmission, because it's in an area of many rivers and where mosquitoes reproduce very easily. And also in Magude district, the Magude Health Center. This Magude district, it has around 50,000 people. And this district has been targeted for elimination, for an elimination initiative, which started in 2015 and led to a substantial reduction on the burden of malaria. I want to introduce here to Gloria Matambiso, which is a junior scientist in CIS. She has been leading this project, and now she's now in Lisbon, in Portugal, starting her PhD based on the results that we have been able to generate through this study. So basically, what we did is to recruit all the pregnant women at first antenatal care visit in these 3 centers, Magude, Manisa, and Ilha. And at that first antenatal care visit, we collected information, HIV status, parity, age, and so on. And we collected a drop of blood onto filter paper to do molecular analysis. So basically to detect the presence of the parasite using real-time PCR and whole genome sequencing of those positive samples. And also, as part per routine, we also collected data on hemoglobin levels of the woman. And in parallel, we collected data on clinical cases in these clinics through the DHIS2 platform, and also on cross-sectional surveys that were done in the communities in these 3 settings. And finally, we use a Luminex-based approach to quantify antibody levels, IgGs, against a set of parasite antigens, including BAR2-CSA as the key one, but also against other antigens, standard ones such as MSP1, EBA 175, and other antigens that Brian and colleagues from London School identified as markers of recent exposure in children. We were especially interested in BAR2-CSA, of course, and we also included peptides covering some specific regions of the protein that we had identified previously as potentially interesting markers of recent exposure to the parasite during pregnancy. So here you can see the numbers, more or less. So we end up during these 3-year periods, we recruited around 10,000 pregnant women at first antenatal visit. After excluding those women that were not from the study area or that traveled during the pregnancy and so on, we end up with around 9,000 women, and we analyzed by PCR 6,500 by PCR and also by Luminex. So around 3,000 in Magude and Manisa, which are big health centers, and around 800 in Ilha, which is a relatively small health center. And on the picture on the right, you can see the distribution of these women in the study area. And here, a description of the woman participating in the study. Basically, among these 6,500 women, we end up with 483 positive infections detected by qPCR, and the parasite rates, as expected, were very high in Ilha, 26%, while in Manisa and Magude were relatively low, 4 to 6%. We observe also that the positivity rate was higher at the beginning of the study, 11% overall, and it declined during the second and third year. And we observe a season effect, so higher parasite rates during the rainy season, and also higher parasite rates as expected among primigravida women, who are the most vulnerable because they lack antibodies against BAR2-CSA. So the first question that we wanted to address is, well, we wanted to compare how the positivity rates at antenatal care clinics compare to clinical cases as data from the DHIS2 platform. This is a comparison that Arnaud Pujol from the team has done. And basically, we have observed that there is a good correlation between both estimates. With the only important element is that there is that temporal trends in pregnant women lag behind trends in children with around 2-3 months. But overall, the correlations are very high with clinical cases. When we compare positivity rates at antenatal clinics with parasite rates in children between 2 and 10 years of age, as obtained through cross-sectional surveys, we observe also a very good correlation between both estimates when we use PCR data, both in primigravida woman and multigravida woman. So the first figure represents all the women, the second one primigravida, and the third one multigravida. However, when we use RDT, so basically when we analyze those infections that are only above 100 parasites per molecular liter, based on the results of the quantitative PCR, which is the limit of detection of RDTs. So when we use this RDT data, we observe that the correlation decreases quite substantially. And this is especially due to a very low correlation among multigravida women, as you can see on the figure on the right in the bottom. So based on this, we wanted to have a look a little bit closer to the effect of parity on these estimates. We know that parity is a very important factor that determines the risk of infection and parasite densities among pregnant women, because, as I said, multigravida women have had the chance to develop antibodies against Bartus-CSA during previous pregnancies, and that leads to a reduction on the parasite rates among this population. So here you can see the two situations: Manisa, which is historically low transmission setting, and Iayosina, high transmission setting. And of course, you can see that in Manisa, parasite rates are very low, and that there is a decline, slight decline in parasite rates by year. And this is what is represented. I don't know if you can see my pointer. Can you see it? Yes. Okay. This is what you can see here in this graph. A slight decrease, very low levels, a slight decrease. In the case of Iayosina, of course, we are starting at higher levels of parasite rates. The first year was around 40-something% of PCR positivity rates, and we observe that there is a decline also in Iayosina by year, and this is observed both in primigravida and multigravida women, as you can see in this graph. However, when we look for the proportion of detectable infections, so meaning the proportion of infections that are above 100 parasites per microliter compared to the overall burden of infections detected by PCR, we observe interesting patterns. So in Manisa, detectability, so the proportion of these detectable infections remain stable during the 3-year periods. In Iayosina, we observe that detectable infections decrease among primigravida and slightly increase among multigravida. So let's focus on this, on two key observations. First of all, detectable infections at the first year, at the moment of highest transmission in both settings, is higher in Iayosina compared than in Manisa. So our question is how we can explain this. Why would we expect higher detectability in Iayosina? Is this due to a higher immunity? Sorry, to a lower immunity, but this is not, it's counterintuitive. What we observe when we measure antibodies against those antimalarial parasite antigens, we observe that immunity antibody levels in primigravida women against DBL Bartus-CSA is quite stable, the same in all the populations, and antibodies against non-pregnancy specific antigens are higher in Iayosina than in Magude and Manisa. So antibodies, the level of antibodies cannot explain the higher detectability, the higher parasite densities observed in Iayosina. The second observation, as I said, is this decline in detectability among primigravida women in Iajosina, and this increase in detectability among multigravida women. So if we go a little bit deeper and we, instead of stratifying by primigravida and multigravida, we analyze secundigravida women, then we can observe that this increase in detectability among multigravida women is due to an increase among the secundigravida women. So something is happening among secundigravida women. Our hypothesis was that there was a waning of immunity, or because immunity is lost, or because there are less opportunities of exposure among secundigravida women during the previous pregnancy. And this is what we observe here. This graph represents the mean annual change in antibody levels in Iajosina among primigravida, secundigravida, multigravida women, and we observe that there is a trend towards reduction in antibody levels among secundigravida women from Iajosina, potentially explaining this increase in detectability, this increase in parasite densities among secundigravida women. So overall, which are the conclusions of this first piece of work? So we can conclude that antibody-based estimates of malaria burden, basically parasite rates, reflect trends in the community, so in children, with a time lag of 2-3 months. However, the diagnostic sensitivity needs to be taken into account at 2 different levels. First of all, we may need to exclude multigravida women in moderate to high transmission settings when we use RDTs, because they have developed some immunity and they can reduce the parasite densities to levels that are not detected by standard conventional diagnostic tools. And we have also observed that there is also a decrease in detectability among primigravida women, which is not explained by changes in immunity. So pointing to the potential contribution of other factors not related to acquired immunity. So the second piece of work that we are pursuing, and specifically are now is the use of new tools to detect hotspots in malaria endemic areas, especially in those approaching elimination. Arnau has been using a function, a 2-point correlation function, which measures the clustering amplitude as in reference to the function of a scale to detect these hotspots. This is a tool that Arnau has been using as part of his studies on cosmology, because he's a physicist and he's adapting this tool for malaria epidemiology. And what he has been observing is that this approach allows to detect hotspots of malaria, of higher malaria burden in using data from pregnant women. And these hotspots are not detected using cross-sectional data as expected. No? So he's at this moment developing this tool and using this EPPIcenter tool. This is the name that Arnau has applied to this algorithm for to study the distribution, the spatial distribution of malaria cases in Mozambique. Using whole genome sequencing data from parasites collected from pregnant women at first antenatal visit and also from children 2 to 10 years of age, we have been able to have a first insight of the genetic composition of these parasites, and using simple approaches as a first stage, basically principal component analysis, we have not observed big differences in the genetic composition in the whole genome sequencing data of those 2 parasite populations, collected those from pregnant women and those from children. What we have observed is that this genetic data shows no evidence of mutations in Kel-13 associated with artemisinin resistance tolerance. No mutations also in PFCRT associated with chloroquine resistance, but a high level of molecular markers of resistance associated with resistance to SP, as based on genotyping data from DHFR and DHPS. So very high levels in Mozambique. The frequency of quintuple mutants is almost 100% in southern Mozambique, a little bit lower in the north, in Cabo Delgado, with frequencies around the 70%. In any case, very high levels of molecular markers of resistance to SP. So based on this preliminary data, we think that ANC-based data can increase the ability to detect hotspots, and that parasite genetic data at antenatal care clinics may be used to infer biological threats in the parasite in the overall parasite population. So which are our next steps? So first of all, we are completing the analysis of serological data, so antibodies against that set of parasite antigens, including Bartus, CSA, and others. This is part of the PhD that Nana is pursuing, and she is at this moment analyzing the serological data, comparing the correlation between seroprevalence and parasite rates in antenatal care clinics, and also the ability to use this serological data to detect hotspots of transmission compared to the data by qPCR. And we are also working on the potential development of rapid test, which could combine the detection of parasite antigens such as HRP2, LDH, but also antibodies against Bartus CSA. In collaboration with Patrick Walker from the Imperial College, we are also, he is basically developing models to predict the impact of interventions based on data collected at antenatal care clinics. For this, we are using the data generated in southern Mozambique, combined with other sources of data to see how this information can provide training data for the models and validation approaches for the models that Patrick is developing. And also as part of the group, and based on that intriguing observation that there is a reduction in parasite detectability with declines in transmission, as observed in Iayosina, that are not explained by immunity, but by acquired immunity. We are also starting a project where we aim to study the adaptability of the parasite to changes in transmission, and specifically the impact that competition, multiple clones in a host could have on the decision of the parasite to invest on sex or replication. And we are, of course, as Brian explained at the beginning, at the introduction, developing approaches in Mozambique to use malaria molecular data to guide decisions, programmatic decisions of the National Malaria Control Program. Basically, this is the use of genomic approaches to provide information of three main use cases. The first one is antimalarial and diagnostic resistance. The second one is parasite importation in areas of approaching to elimination. And the third one, the use of genetic diversity data to infer the burden of malaria and the effectiveness of the interventions in driving a decline of malaria in targeted areas. And of course, using parasites from pregnant women as a sentinel population to address these use cases. This is the GenMOS project funded by the Gates Foundation, and this is the project where we are working together. Brian's team, the team at Manisa, and is global, IDM, Institute of Disease Modeling in USA also, Malaria Consortium, and the National Malaria Control Program in Mozambique. So to address this, what we are doing is we have established a sampling scheme in the whole country in Mozambique. We have selected sentinel sites in 10 of the 11 provinces in Mozambique. We are targeting health clinics, so children attending with a malaria, with signs and symptoms of malaria and a confirmed malaria infection by RDT. We are also including pregnant women at first antenatal visit. We are also doing a dense sampling in malaria elimination areas in the south, so basically Maputo province, and this implies collecting biological sample from all the clinical cases that are detected in these low transmission settings. And we are also implementing a sampling strategy in the context of those interventions that are happening in the country, in Mozambique, which are basically seasonal malaria chemoprophylaxis, perennial malaria chemoprophylaxis, NDAs with ivermectin, and NDAs with DHA piperaquine, and also intrador residual spraying activities that are happening in the country. So basically, we are doing a pre and post sampling, collecting parasites before the intervention, after the intervention. And at the same time, we are building capacities in Manisa Health Research Center to perform the sequencing, a targeted approach, multiplex based approach, building from the work that Brian and team has developed on micro-haplotype strategy. So we have been acquiring the MySeq for sequencing. Now they are in the laboratory, and training the team there to perform this sequencing in the country.
We're getting close on time there.
Sorry?
We're getting close on time. We have 10 more minutes.
Perfect, I'm finishing. So that
Okay.
is great. Thank you, Teresa. So as I said, as part of this sampling strategy, we are recruiting pregnant women at first antenatal visit in several sentinel sites. And here you can see a first insight of the data that we are generating. So parasite rates, positivity rates by RDT ranging from 13% to almost 50%. So a wide range of intensities of burden of malaria in pregnancy. We are now completing the analysis, doing the PCR confirmation, and so on, and comparing this data with DHS2 data, so clinical cases. So at the end of all these efforts, what we would like to do. So our goal. So basically, our dream would be to develop like a toolkit for surveillance of malaria in pregnancy, which could allow us to address 3 specific use cases. Now, the first one is use surveillance as a core intervention, both in control settings and elimination settings, which would make easier malaria stratification, assessment of coverage data, biological threats, and use ANC data as index cases for targeted interventions. The use again of data from antenatal care clinics to assess the impact of drug-based interventions, both at individual level response and at the community. So interventions such as PMC, the all IPTI, and NDA, using the information of pregnant women as an indicator of transmission in the overall community, and basically improve the health of pregnant women through this approach, increasing the ability to treat infections in first trimester, which currently are not targeted, and as an adjunct to mass drug administrations, because again, pregnant women at first trimester have to be excluded in mass drug administration campaigns. So this is our medium long-term goal, and this is where we are trying to arrive. And to arrive here, we are super happy and lucky because we have a very nice team. Here, the figure in the left, this is a traditional festival in Catalonia where people build these human castles, and this is trying to express all the people that is putting together the energy to keep the castle to the top. And this castle, in our case, is built with a very nice team in Mozambique. As I said, Gloria Matambiso, who has been leading this MIP-MOM project funded by NIH, and a team at the nurses and the health clinics, field workers, and data clerks, and so on. We have a super team also in GenMos, Clemente and Simon and Kiva as the key players in this project, with the help of Nello and Enriquez, and Sonia and Ose from the Malaria Consortium. Fantastic team in Barcelona, Edu Rovira, Carla, Debayan, Pau, Arnau, and Nana. And our friends in UCSF, Brian and Andres, and of course the colleagues at the National Malaria Control Program, Baltasar Candriño and Bernadette, who have been very helpful in trying to understand the complexities that the National Malaria Control Program faces in their daily life when taking decisions, and the needs that they have to take the most impactful decisions. So yeah, thank you very much to everyone.
That was great. That was a lot of amazing work. Thanks, Alfredo. So let's start with questions from the broader group.
Alfredo, could you unshare so we can see each other? That'd be great.
Okay, yeah. Okay.
Yay.
I mean, I definitely have some questions, but I'm going to have a little bit of extra time with Alfredo later. So are there other questions kind of from the broader group?
I have a question.
Go ahead, Jenny.
Thank you, Alfredo. That was a great talk. I really enjoyed it. I'm really interested in ANC surveillance also, and I wondered if you guys had thought at all or done any work around like the sampling requirements for decision making, just in terms of costs and feasibility for scaling up or continuing this program. Have you thought at all about like the numbers required and the geographical or temporal sort of sampling resolution needed for decision making?
So in terms of cost and feasibility, we have not done formal analysis of that. So there is no data. However, the strategy is building from an ongoing ANC activity. So at ANC, as per routine, at first antenatal visit, the nurses do testing for HIV, do tests for hemoglobin, for syphilis. So how you say that the platform is there. It would be to integrate a new thing, which is the test on malaria. Potentially, I think potentially should not be very costly. I think that the issue would be more in terms of the workload for the nurses working on the ANC clinics. But I don't have precise numbers of costs, and to answer your questions. In terms of sampling, again, we don't have specific estimates. It will depend on the use case, the magnitude of the clinic, and the transmission intensity in that area. So I think each scenario would require an estimation. In GenMOS, what we are targeting as and this is overall estimate, we are targeting 500 pregnant women, positive pregnant women per year. So this is our target. But as I said, I think we as part of GenMOS, we will have to estimate very precise estimates based on the use cases and the burdens of malaria.
Yeah. Okay, thank you.
Thank you, Jennifer.
Other questions? If not, I'm going to ask one. That's a threat, so speak up.
I'm going to ask a pretty simple one. I'm sorry, I'm not really familiar with the way that the clinics are set up in Mozambique. Do you do antenatal clinic? Is the clinic for pregnancy the same clinic that people are going to when they're ill, or are they separate?
They are separate. Okay. So in each hospital there is antenatal care room, let's say, where all the pregnant women arrive, and as per routine, the nurses call first to the woman attended for the first time and attend in that room the woman, and then the rest of the women, and then there is a maternity area where women deliver, and the outpatient area where the persons with signs of symptoms of malaria go to. So different spaces.
Good to know. Thank you.
Thank you, Teresa.
Alfredo, here's a quick question about the serology, combining serology and the ANC surveillance. You make a very good case for how ANC surveillance can be an efficient way of doing surveillance in general and filling some gaps. And you could do serology that's kind of just general serology, like the markers, or you could focus on the VAR2-CSA. And I was wondering if you had any thoughts yet, either conceptually or based on existing data, as to how those data give you different information. Is one better, looking at kind of, again, the general serology versus the VAR2-CSA in that population? Does one give you different information, better information, or is this something that you still feel like you need to explore further before you have the answer?
Yeah, thank you, Brian. So for me, the added value of serology in pregnancy is for VAR2-CSA, because I think what is especially interesting is relatively recent exposure. So exposure during the last few months, not exposure during the last years of life, which is what we would get with general antigens, not pregnancy specific. What we observe is mainly that pregnant women do have high antibody levels against MSP1, EVA 175, and others, because of course they have many years of exposure to malaria parasites. So the added value of pregnancy-specific serology is that it would allow us to detect exposure during that pregnancy, especially among primigravida women, which I think is more actionable in programmatic terms, to take decisions. Yeah. So
you mentioned primigravida. Obviously, that would be an important factor in determining how to interpret the data or how to do the sampling. And I guess also maybe when during pregnancy, right? If your entire period of potential exposure is less than 9 months, then when during that 9 months you sample somebody is also going to be pretty important. And I guess the extent to which you can accurately date somebody's pregnancy will also influence how you interpret your results.
I agree. I think those are the factors. So potentially, I mean, our interest ideally would be to detect short-lived antibodies to be able to include also multigravida women. So that would avoid the need of I mean, to reduce the sample size by focusing on primigravida, because if we detect, so if we focus on short-lived antibodies, then we could use multigravida woman as primigravida woman the same way. Yeah, but I agree with the other point that you pointed out on the need of understanding the windows of exposure and having that information to extract conclusions.
Great, super exciting. All right, we're at the top of the hour. Any final questions? All right, if not, I'd like to thank Alfredo again for a fantastic seminar, joining us from all the way in Barcelona late in this evening. Thank you so much. And Alfredo, do you have the link for the next the brief meeting?
Okay, I have the link.
Okay, great. All right, I'll see you in a couple of minutes. Everyone else, thank you for joining.
Thank you to you. Ciao, ciao.